The human venous system contains approximately 60% of the body's total blood volume. In the lower extremities, this creates a massive biological reservoir. The moment we stand upright, gravity dictates the physics of the leg. A hydrostatic pressure gradient forms instantly, subjecting the veins at the foot to a resting pressure of approximately 100 millimeters of mercury. The physiological challenge is absolute. The body must return this deoxygenated blood upward to the right atrium, but it must do so without the active driving pump of the heart. To counter gravity and continually clear that volume, lower limb venous return relies on a specialized secondary mechanical system. The core of this system is the deep venous network. These capacious veins strictly accompany the arterial tree, sequestered beneath the deep fascia of the leg. Above that fascial layer lies the superficial system. While highly variable in its specific anatomy, it relies primarily on two main axes, the great and small saphenous veins. Connecting these two isolated networks are transfascial perforating veins, which pierce the deep fascia and contain internal one-way valves. This anatomical arrangement provides the strict framework necessary for fluid dynamics, forcing blood to move in a single direction, inward from the superficial tissues and upward toward the heart. The engine driving this flow is the calf muscle pump. During ambulation, the gastrocnemius and soleus muscles engage, acting upon venous cavities called soleal sinusoids. As the muscle contracts, internal pressure spikes up to 300 millimeters of mercury. This compresses the deep veins, forcing blood proximally up the leg. As the muscle relaxes, competent valves snap shut to prevent backflow. The resulting pressure drop acts as a vacuum, drawing fresh blood inward from the superficial system. This line graph illustrates the physiological result of that continuous ejection cycle. During active walking, superficial pressure plummets from 100 down to roughly 30. Look where the graph levels out. This equilibrium point is where superficial inflow matches deep vein ejection. By continuously clearing the venous reservoir, a competent calf muscle pump prevents internal hypertension and protects the lower limb's soft tissues. When the system fails, pathology does not begin with a mechanical valve tear, a common clinical misconception. Failure actually initiates at the cellular level. Localized inflammation in the vein wall triggers smooth muscle cell proliferation and abnormal collagen deposition. This inflammatory remodeling degrades the wall's structural integrity. The vein loses its compliance and begins to physically dilate under normal pressure. As the vessel widens, the valve leaflets attached to its walls are physically pulled apart. They lose the ability to coapt or seal shut. To map this structural failure before intervention, clinicians rely on duplex ultrasound. This spectral Doppler trace captures the strict clinical definition of superficial reflux. The red tracing indicates retrograde blood flow, moving backward with gravity, lasting longer than 0.5 seconds. Once valves fail, the hemodynamic baseline reverses. Gravity pulls the blood volume backward, imposing an elevated pressure on surrounding soft tissues that drives further dilation and failure. This state of prolonged, uncorrected retrograde flow is defined clinically as ambulatory venous hypertension. Pushed outward by chronically high capillary pressure, the macroscopic axial vein is stretched to its limit, forcing it to elongate into a twisted, tortuous shape beneath the skin. Clinicians stage the progression of this tissue damage using the CEAP classification system. This photograph demonstrates CEAP Class 2. The hydrostatic damage is visible at the surface as bulging, elongated superficial varicose veins. If uncorrected, the limb degrades to CEAP classes 3 and 4. Chronic fluid leakage causes extracellular edema, visible skin eczema, and dark pigmentation. The pathology reaches its end stage at CEAP class 6. Chronic inflammation hardens the calf into a fibrotic state, known as lipodermatosclerosis, which ultimately erupts into an active, full-thickness venous ulcer. Superficial venous reflux is a progressive, destructive physiological cascade. Halting the damage requires definitive structural intervention. For decades, intervention meant open surgical ligation and stripping. Today, minimally invasive endothermal ablation has become the primary treatment for superficial incompetence. During this procedure, the clinician uses ultrasound guidance to insert a catheter percutaneously. They target the incompetent axial vein strictly from within its own lumen. Before thermal energy is applied to the vein wall, the vessel is surrounded by a specialized fluid called perivenous tumescent anesthesia. This ultrasound cross-section shows the first ole of tumescence. The bright fluid halo compresses the dark circular vein, emptying it of blood for direct thermal contact. Simultaneously, this fluid separates adjacent nerves from the treatment zone, acting as a thermal heat sink. This mechanical isolation makes intraluminal thermal destruction both effective and structurally safe for the surrounding limb. With the vein prepared, a laser fiber or radiofrequency coil delivers a dose of energy, typically between 60 and 80 joules per centimeter. As the thermal energy contacts the endothelium, it instantly denatures the collagen. The vein wall rapidly shrinks and collapses inward behind the catheter. This controlled thermal damage initiates a biological response. The body initiates a fibrotic reaction that permanently occludes the lumen. Unlike traditional stripping, which physically removes the vessel from the leg, the fibrotic cord remains in place, avoiding the associated tissue trauma. By permanently occluding the failed superficial access, the pressure gradient normalizes. The deep system is restored to efficiency, allowing the calf muscle pump to clear the venous reservoir against gravity.